Hello everyone, welcome to another episode of Next Saviours Essential Question Series for NEET PG 2025. Today we are going to discuss a very important topic which is almost every year kept in the examination, and that is ECG changes in electrolyte imbalances. You see, there are three ways in this the question could be framed. One is that they give you a ECG and then they ask you what is the electrolyte imbalance due to which these are the ECG findings. Another way is the theoretical question where they are directly asking you about the ECG abnormalities related to that particular electrolyte finding, or it could be a part of a long question where the ECG is also given and then you have to identify that what is the electrolyte abnormality in relation to that particular ECG finding in the question. Now, what are the particular electrolyte imbalances over which the ECG findings are asked in the question? One is hyperkalemia and hypokalemia. The other one is hyper and hypocalcemia. And the third one that could means rare entity is hyper or hypomagnesemia. Now, majority of you might be thinking that why not hyponatremia or hypernatremia? Because sodium is particularly because it plays a crucial role in generating the action potential in the cardiac cells, and particularly during the phase 0, that means the rapid depolarization phase. So you see, the reason is that extracellular sodium concentration changes, but it does not significantly affect the resting membrane potential. And as a result of it, there are not significant ECG changes because the intracellular to extracellular sodium gradient, it remains relatively stable due to tightly regulated hemostatic mechanisms. And that is the reason why it is never kept in the question, because there are no significant findings related to that. So let's start with the most important question, and that is the ECG findings that are seen in hyperkalemia. You know, hyperkalemia can be divided into mild, moderate, or severe, depending upon the levels of the potassium in milliequivalent per liter, like 5.5 to 6.5 is categorized as mild. And this ECG changes, theoretically, you already are aware, like there is going to be a peaked T waves, while in case of moderate hyperkalemia, there is going to be a widened QRS complex, while in case of severe hyperkalemia, there is going to be a sine wave pattern. So let's see how does this appear on the ECGs. Now, all of you know that what happens in hyperkalemia, that the extracellular potassium concentration, it is increased, which reduces the gradient between the inside and outside of the cell. As a result of which, the resting membrane potential, it becomes less negative. Like if I say that the resting membrane potential, for example, is minus 90 millivolts, so it becomes minus 80 millivolts because of hyperkalemia. So it is responsible for partially depolarizing the cell. And you know, this T wave over here on the ECG, it represents the ventricular repolarization, which correlates with the phase 3 of the cardiac action potential, which in turn is primarily driven by the potassium efflux. So what happens in hyperkalemia? This increased extracellular potassium enhances the driving force for potassium to leave the cell during repolarization. Now, this results in faster repolarization, as a result of which this T wave becomes taller and narrower. And this is the exact finding that we see in case of mild hyperkalemia, that the T waves becomes peaked. And how are they going to appear on the ECGs? This is how the T waves, the peaked, that means tall T waves, are seen in the ECG leads, and they are particularly more commonly observed from V2 to V4 because of the vector gradients. Now, what happens in case of moderate hyperkalemia? As you know, the QRS complexes, it represents the ventricular depolarization. So that is correlating with the phase 0 of the action potential. This is where the QRS complex represents ventricular depolarization. Now, depolarization, it relies on the rapid sodium intracellular influx through voltage gated potassium channels. You already are aware of this fact. And in hyperkalemia, the resting membrane potential becomes less negative, as we have just talked about. So it results in partial depolarization of the cardiac myocyte and inactivation of the sodium channels because they remain in the refractive state at the less negative potential. So sodium channels available, phase 0 depolarization, it slows down, right? So it results in the slower conduction through the Purkinje fibers of his system and ventricular myocardium. So this is manifested as a widened QRS complex in case of ECG, as it is very clearly evident over here that the QRS complex is widened, right? And you all know all the reasons behind that. Now, another point is that because of this partial depolarization of this AV nodal cells, it leads to slower conduction through the AV node. And this causes delayed impulse transmission, resulting in the prolonged PR interval. And in some of the cases, like not all, there could be a presence of the flattened or absent P waves also. Like why? Because P waves, it represents atrial depolarization, and the atrial myocardium is highly sensitive to the increased in extracellular potassium levels. So what happens in moderate hyperkalemia? Atrial cells are not adequately depolarized, which leads to slower and weaker atrial conduction. So it results in flattened P waves, although in this ECG, there is no flat P wave, but these are the two findings which can be very clearly seen over here. And these are the findings which are usually kept in relation to this moderate hyperkalemia in your questions also, that there is a widened QRS complex and there is going to be a prolonged PR interval too, right? So these are the two findings that you have to remember related to this particular one. Next is severe hyperkalemia. When the potassium levels goes beyond 7.5 milliequivalent per deciliter, it results in severe hyperkalemia. Now, we have already talked about this, like when depolarization is slowed, it results in QRS complexes, which continues to widen due to depolarization. The T wave remains peaked from the rapid repolarization. And as a result of which, you see, this QRS complex, which is widened, and the tall T waves, it fuse to form into a single undulating wave that resembles a sine wave. So this is the ECG finding that is very, very importantly or commonly presented to you in cases of severe hyperkalemia. Atrial myocytes are more sensitive to hyperkalemia than ventricular cells. So severe hyperkalemia lead to flattened or absent P waves also, which could be due to the suppression of the atrial depolarization, and PR interval might also be prolonged. But most importantly are the sine wave pattern, which is on the basis of which you will identify that the question provided is that of a severe hyperkalemia, and you came to know the reason about this too. And this is how in ECG this is identified, where there will be a fusion of a T wave and the QRS complex leading to into a single undulating wave that resembles a sine wave. So hope you have understood how these ECG findings are going to appear for severe hyperkalemia. Now the table that we have shown in the beginning makes more sense and with more understanding that in case of mild hyperkalemia, it is going to be identified by tall, narrow, symmetrical peak T waves. For moderate hyperkalemia, it will be identified by widened QRS complexes in particular, and obviously there is going to be a prolonged PR interval with or without flattened P waves. But in case of severe one, it is identified by the sine wave pattern, and this is most commonly kept in your questions in particular. And this sine wave pattern is a preterminal rhythm. So if it is not promptly treated, it will quickly progress to the ventricular fibrillations and asystoles. Ventricular fibrillation, as it is identified by disorganized ineffective contraction, and asystoles means complete cessation of the electrical activity. And the next one is the hypokalemia ECG findings. The most important ECG finding is the flattened T wave, or you can say inverted T waves, which is being shown over here. The other one is the prominent U waves, which is best seen in the V2, V3, ST segment depression, and prolonged QT interval because of prolonged repolarization. Now, let's see what are the reasons behind the flattened or inverted T waves. Now, you know that the T wave, as we have already talked about, that it represents ventricular repolarization. That is, it is correlating with the phase 3 of the cardiac action potential, which is primarily mediated by the potassium efflux from the myocyte. Now, in hyperkalemia, what happens? There is a reduced extracellular potassium concentration, which results in the decreased gradient for potassium to exit. And this leads to slower and less efficient repolarization, as a result of which the T wave is either flattened or it is inverted. So inverted in case of more severe cases because of significant repolarization delay, while majority of the times it could be flattened in mild to moderate sort of the hypokalemia. So that is reason number one. Now let's see what is the reason for this prominent U waves. As you already know that U waves, it represents the after depolarization that occurred during the terminal phases of the repolarization or possibly during the early diastole. So their exact origin, although it is debated, but it is thought to be arising from the delayed repolarization of the Purkinje fibers or the mid-myocardial cells. So in hypokalemia, what happens? Because ventricular repolarization is prolonged, so it leads to prominent U waves, right? So there will be a prominence of the U waves, and this prominent U wave is a specific finding for this hypokalemia. If at all the examiner tries to give you a question related to this hypokalemia, then he likes to give it so that it can be easily identified. Although I gave you the hypothesis or the reasons behind this prominence of the U wave. Next is the ST segment depression. The ST segment, it represents the plateau phase, this phase of the cardiac action potential. Now, in hypokalemia, the delayed repolarization affects the overall shape of the ventricular action potential, it leading to downsloping or horizontal sort of a ST segment depression. So this ST segment depression is diffuse and it should be differentiated from ischemic ST segment depression, which is more localized and often accompanied by the chest pain. And finally, the prolonged QT interval, which is because of the prolonged repolarization. You see, the QT interval, it represents the time from ventricular depolarization to the end of repolarization. In hypokalemia, the prolonged repolarization, which is because of reduced potassium efflux, extends the T wave duration, so it results in an overall prolonged QT interval. So, hope you have understood the important findings on the basis of which the ECG of the hypokalemia is to be identified. And as you can see, the most prominent features are the this T wave inversion, and the other one is the prominent U waves. So, examiner likes to keep these two as a finding for you to identify the ECG of hypokalemia. Thank you very much. The lecture is going long. We are going to discuss this hypocalcemia or hypercalcemia, hypomagnesemia or hypermagnesemia features tomorrow. All the best for your future endeavors and examinations. May you reach the zenith in your life. In order not to miss any update related to our content or related to the NEET PG preparation, please join our Telegram group. The link is shared below.